Good morning, ladies and gentlemen. I'm very glad to be here today, and especially for the last 2 days. I've really felt compelled that every discussion has been about someone who works in the government system, talking about how services are provided for young people. And it's been a very serious reflection for me. One time, Trevor invited me for a panel discussion, and he told me it is X space. And I asked him that I cannot manage to join that X space because I am not on Facebook and I'm not on Twitter. So he toned it down and said, okay, we're going to do a Zoom discussion. I'm bringing that forward because I want you to understand that as we talk about technology and taking technology to the implementation arm from the government, you need to help us change the mindset and work together with us as we discuss. And I think that is the biggest highlight that I've picked from this conference. So I'm here to talk about our experience, especially in addressing barriers to uptake of oral PrEP, prophylaxis among AGYW, using the community approach. I'll just go straight to the background. That slide is a bit crowded, but it brings out especially what the situation is in Uganda. I know that you have listened a lot to the statistics globally for the last 2 days, but also as in Uganda, we have a number of challenges in terms of exposure to HIV, and especially among AGYW. And you can see the prevalence, which is 3 times higher. Even incidence is much more higher among AGYW. And really, they account for most of the new infections in our country. We are not so different from the other East African countries or the African countries. Even condom use is still low among young people. And the precurrent speakers just talked about condom use as well. And we're still yet not doing very well in terms of knowing our HIV status, especially for young people. And similarly, the ART coverage is still low. And just to say that even viral load suppression among young people is both males and females is still low, and that percentage is a population-based percentage. Just talk about quality improvement. In our country, we have, as you know, Uganda has so many documents. We are known for developing guidelines, and very many countries come to learn from us and really go faster than us. But just to say that we have a very robust quality improvement program for HIV. We have a quality improvement framework with a strategic plan for the HIV response. And most of our interventions have been integrated into this framework. And just talk about PrEP, especially oral PrEP. I think we're hearing examples from Uganda for PrEP and also other biomedical interventions that are coming in. Some of them have not yet been scaled up to the rest of the country, but oral PrEP is what we can proudly talk about to have been largely scaled up. And it is part of our guideline as Uganda, and it is recommended that AGYW at substantial risk of, okay, thank you. So because of that recommendation, we realized that following from the DREAMS program, and looking at our DHIS2 data, we found out that PrEP uptake among AGYW was really low. And we already had quality improvement, which was happening at facility level. But because most of the AGYW were at community level, so we initiated the quality improvement approach. So when we started this intervention, we started first with a baseline. And you can see the results that came from the baseline that we started with in 2021. And we found out that performance for those two indicators was really low, like you can see in the slides, in the months that we picked, September, October, November. And so we started this quality improvement approach, and the broad objective was to improve prevention services for adolescent girls and young women. And then the specific objectives was to increase to 100% the proportion of AGYW aged between 15 to 24 years that have been screened for PrEP eligibility, and to increase to 80% the proportion of PrEP eligible eligibility and those initiated for PrEP still in that age population. So we had a number of methodologies that we used. First of all, we implemented it in all 7 DREAM-supported regions. Those are the regions. And these regions are in the red corridor in our country with very high HIV prevalence and incidence among AGYW. And we developed a number of documents that guided the implementation process. We had coaching guide tools. We had a number of monitoring and evaluation documents that we developed as well that we used to guide implementation. And we had a number of interventions that we implemented, including forming community QI committees with AGYW peers. We did awareness creation. We had monthly coaching visits at safe spaces. We had monthly review meetings. We had a number of quarterly mentorships. We had learning sessions. And finally, we had a national QI harvest meeting, which was done at national level. So that was the structure of our community QI collaborative. Like you can see, that is the structure that we have in Uganda. From the district level, you go to a sub-county. So at sub-county level, we had a coach, a trained coach, and then at parish level, where we have a health center too, we had the community QI committee that was led by trained peers, and then the interventions happened at safe spaces at community level, at village level, where we had services provided to AGYW, and we used the DREAMS layering table for them to access services. But we had national level programs going on as well to support in terms of testing the changes and looking at the common indicators and support peer learnings as well. So that is the community QI model that we used, using the famous quality improvement approaches. But very important for us to emphasize that we set up community improvement teams and make them functional using the interventions that I've talked about above. And then we supported teams to continuously use the data to identify gaps and propose and test solutions, and then facilitate cross-learning among the teams to spread good works that had been identified. So with the results, we used the RCA model, the root cause analysis, to identify the barriers, which helped us to really provide evidence-based interventions. But these were the barriers, some of them that were identified that we addressed. Fear of being seen picking or carrying PrEP drugs from the HIV clinic, stock out of testing commodities, far distances to health facilities, inadequate information on PrEP, myths and misconceptions around PrEP use. Some partners refused the AGYW from taking PrEP, and lack of integration of PrEP screening in other services. And then when we did the intervention, we realized that we had a marked improvement in terms of the interventions that we did, and these were the results, just like you can see from this slide. And we picked 2 indicators, that was PrEP screening and PrEP initiation. And you can see that PrEP initiation increased as of March 2023, we're about 77% from the 30% that we started with. So in conclusion, would say that the Community QI initiative effectively addressed the barriers to PrEP uptake among AGYW. This is just some of them, but you saw the barriers above, such as stigma, misinformation, and logistical challenges. And through selected interventions, which I have talked about already, we're able to increase uptake from 30% in March 2022 to 77% in March 2023. But also this highlights the success of targeted community-driven strategies in enhancing HIV prevention efforts for vulnerable populations. And as I end, I would like to say that we developed this change package, and now it has informed programming at national level, but also has informed some of the community-based interventions for AGYW using already the existing DSD models that we have in our country. So I'd like to appreciate all those organizations and line ministries and the AGYW peers that worked very hard with us to help us bring this intervention this far. Thank you very much for listening.